Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Today we have a very, very special guest with us, Dr. Edward Zuckerberg, who will be joining us on the topic of the oral systemic connection in artificial intelligence. As you guys may know, we just concluded a webinar that was regarding the technology aspects of implementation of artificial intelligence in our practices. But now we will take that a step further and try to make the oral systemic connection utilizing AI. Before I introduce the co-host and the speakers of today, our general updates for the year and the latest projects that are on the agenda. As you guys may know, we will be soon launching the Dentistry Fund, the first of its kind, for off by and for dental professionals. The Dental AI Association is in the works. The Top Doc Club is going to be launched as well simultaneously. And the hospital project is progressing very well. More updates on that after our February meeting. And let's get started. Please continue sending us your favorite doctors in terms of nominations. This year will be our last class to reach 1,000 top doctors, hopefully out of 200 countries. Um, to start with the topic today, I just kind of briefly wanted to introduce. You guys know Dr. Locke very well. He's a constituent of the Global Summits Institute. He will be co-hosting the session today and asking all the important questions. As to our speaker of the day, so I have gotten the honor and privilege to get to know Dr. Zuckerberg over the years, following his career and what his passions are, and where he was and where he is now. He's been in private practice for over 45 years. He started as a general dentist and ran a practice in Brooklyn for 34 years before moving out here in California in 2013, around the time when I started getting to know him a little better. He has focused his career mainly. I gotta explain to you guys, in his practice, he did a lot of startup experiments where he had technologies that he tested, and I'll go over some of those as well. But lately, he's been doing a lot of podcasts and webinars regarding social media marketing, online reputation management, and technology, which was his passion. And lately, there's another passion that involves taking dentistry closer to medicine and create and eliminating that gap that we have from the medical dental perspective. He also consults a lot of different startups when he finds free time. He's also wrote numerous chapters and magazines and books and articles regarding these very topics. So they fostered essentially a home where technology was essentially taken to a whole different level, as you guys may know. His involvements with various universities such as Harvard and companies such as Meta and so on. It's a great honor and privilege to learn from our colleagues that have had the experience of so many decades, so we don't make the same mistakes and also benefit from their advice. Currently, he practices minimally and loves to travel with his a wonderful wife of some 40 plus years. And once in a while, they also end up in our neck of the woods where I get the pleasure on having some consultation sessions one on one. They currently have seven grandchildren. You guys may know Dr. Zuckerberg posts a lot about health concepts, health foods, and the time that he gets to enjoy with his grandchildren and his back and forth travel with New York. With that simple introduction, and the list is sort of way too long for me to try to cover here of the accomplishments of Dr. Zuckerberg, but we'll just kind of get started there and maybe he can give us a little background. Dr. Zuckerberg, thank you for joining us. Dr. Locke, thank you for co-hosting the session. What is your motivation? What is the end goal? We have you on mute, Doctor. If you can hop on, it's great.
Yeah. First of all, thanks for having me on, Kianor, and good to be together with you again, Locke, as well. I know we've done a couple of podcasts together. And the first thing I should correct is you must be reading from an old bio because we're up to 10 grandkids now.
Oh
Our
man.
new, our newest, our newest edition is less than well, actually just a little more than 3 weeks old. So
Congratulations.
spending a lot of time up in San Francisco, which is why we haven't been spending more time down in your neck of the woods, but we'll make it down there next week. Uh,
Lovely. I look forward to it.
you know, when I moved to California from New York, uh, which was complete and official about 10 years ago, the last thing I wanted to do after 35 plus years of practice and practice ownership was to set up my own practice again. So I was looking for a way to give back to my colleagues, and my knowledge base was mostly centering around technology integration in the dental office, being an early adopter of things like digital x-ray in the late 90s, building my own electronic health record system in about 2005, implementing CAD/CAM in 2008. I mean, before that, I had an IBM PC XT in my office in 1986, which was unheard of. I mean, that was a ridiculously weak computer, but got in on the ground floor and hey, artificial intelligence, right at its start using computers. Intraoral cameras, air abrasion lasers in the early 90s. And then, of course, with my wife of 44 years, Karen, I got her to leave her psychiatry practice to run everything non-clinical in my office in 1995. And over a 10-year period, we kind of transformed the practice to one that really specialized in caring for phobic patients and utilizing technology to make the dental experience pleasant for them and for all dental patients, so to speak. But it wasn't, around the time that we shifted our base to California, which, had something to do with my son starting this little startup that a few people have heard about. That, by the way, is celebrating its 20th birthday today. I don't know how many of you knew that, but February 4th, 2004 was the launch day of the Facebook. So here we are on their 20th birthday. And
I gotta add to that. This is funny because February 4th is also my mom's birthday, who's it's a very cherished day for me as well. So February 4th, huh? Lots of things happening on February 4th. That's exciting.
there you go. So, around that time, people were starting to find out about my existence. Obviously, a big push for that came from Howard Ferran of Dentaltown, who was having a problem with his own Facebook page and found out that Mark's dad was a dentist and reached out, and I helped him with his problem. He coerced me into writing a couple articles for Dentaltown, and from there, the requests to advise startups and lecture took off. And over the period from 2010 to 2019, I was doing a lot of traveling to lecture at dental meetings, working with private dental offices, study clubs, things of that nature, about technology integration, social media marketing for your practice, areas that I knew enough about to really help people along. And with the start of the pandemic, it seemed like this might have been my chance to ride off into the sunset. But, lo and behold, I got involved with the team at Keystone Bio and the team at Viome, who were doing groundbreaking work on the oral systemic connection and eradication and minimization of many of the diseases that up to now we don't have good care for. Heart disease, diabetes, dementia, digestive cancers, you name it. So today I hope to delve a little bit into that topic of what that connection is, what we need to know about that connection, and then how these companies use artificial intelligence to bring about an efficiency that will hopefully be transferred to today's practitioners to help take care of their patients and really minimize the extent of systemic diseases that have their origins in the mouth.
Awesome, Dr. Zuckerberg. Dr. Shah, thank you for allowing me to join you as the co-host today. I can't wait for Dr. Zuckerberg to share the update. In the past, we have at least twice interview on my channel. So let's keep it rolling.
Excellent. So when you say the oral systemic connection, that's a big deal. What can we expect today out of this podcast? I mean, yeah, oral systemic connection. We know as dentists that we are the first line of defense, and outside of your skin, everything that goes into your body is through us, to the oral cavity, right? That we're responsible for. How can we improve our
You know,
diagnosis, catch things early?
I've been a dentist since 1978, 45 years. And it didn't take long in my career to see the connection between what happened when a patient opened their mouth, what's going on in their mouth, and what's going on in their whole body. You know, anecdotally, of course, without a scientific background, I had a patient that brought in her husband who hadn't been to the dentist for 20 years. He was 38 years old and she just didn't want to kiss him anymore because his mouth was disgusting. And sure enough, when she got him in, we saw plaque and tartar caked up. We couldn't even see his teeth. My hygienist was essentially going in with a giant, Cavitron blasting away the plaque and tartar. She came to me about 15 minutes later and said, I normally change the filter on my saliva ejector at the end of the day. I've already changed it 3 times on this guy in 15 minutes. And as I'm removing some of the plaque and tartar, his lower anterior teeth are going to fall out. They're being held in by calculus bridges. We've all seen cases like that. We put together an extensive treatment plan for the patient that involved extraction of a number of teeth, periodontal surgery, prosthetic care, etc., which the patient did not go ahead with, sadly. And I heard about 3 to 4 years later, I think at the age of 42, the patient passed away of a massive heart attack. Now, that's an anecdotal story. I can't make a scientific connection based on that. But when you see things like that happen again and again, when a patient who's 4 months pregnant comes in with an abscess and a swollen face, and I take a radiograph and see periapical pathology and a root canal that's well short of the apex, and I know that endodontic therapy needs to be retreated, and the patient refused care, even though her physician wanted her to go through care in the middle trimester, which is the least disturbing time to the fetus. And we were ready to go. A course of antibiotics removed the swelling, made her feel okay, and she put off treatment till after the baby was born. Well, unfortunately, 2 or 3 months later, she lost the baby for a miscarriage. And wow, again, it makes you, as a professional, when you see this happen over and over, you know that what's going on in the mouth is connected to everything else systemically. But we had very little information on how the process occurs. And if you ask most dentists, they are like, well, there's bacteria in periodontal disease, there's bacteria in the mouth. When the gums are inflamed, the capillaries are inflamed, and that bacteria is being going into the bloodstream and going to other parts of the body and causing disease. Very vague terminology. Well, the good news is we understand the process with much greater detail today, and I'm going to share some of that detail with you right away.
Before you share that, Dr. Zuckerberg, can I ask you a question? You are consultant for both company, the Ketones Bio and the is that Vimo? You said
Biome,
Biome.
yes.
Yeah.
Yes, my role is a chief dental officer for both companies. In addition, I advise many other companies, including Velmini, who I know you had on Podnar earlier this morning. Proteusite, which is doing groundbreaking work with AI and oral cancer detection, which I hope to have time to discuss about them today also. And, you know, at some point, all these companies that are doing these breakthrough technologies, they need funding, right? So that's an area that I've become fairly knowledgeable about. My youngest daughter, who just had our 10th grandchild, is a partner at a venture capital firm. And, you know, I've learned more about how venture capital works. And I've actually been now a partner for 3 years at Revere Partners, which is the only independent venture capital fund that invests solely in oral healthcare companies. And Revere has provided financial assistance to both Keystone Bio and Viome. And without them, many companies with great ideas and ways to move us forward would be unable to bring their products to market.
Yes, a lot of times we start exciting projects and we come to a very strong halt due to finances and funding and so forth. That's great to know that you do this as well. So that's wow, you're a pretty busy guy for someone that's getting closer to retirement, no?
You know, I haven't done much, wet finger dentistry in the last 10 years, although I do have some family members that still demand me to be their dentist. So I keep my skills sharp, and I still, when I'm trying out products for companies that, ask me to help them bring products along, sometimes I need to see those products in action in the mouth. So I do keep a part-time dentist relationship with the great folks at Cupertino Dental Group up here in the Bay Area. And, you know, between the balance between some dentistry, consulting, advising, my roles as chief dental officer, parent of 4 and grandparent of 10, and loving spouse, life is busy, yes, but it's fun.
Good. Well, our audience is very excited to hear what you have to say. I just saw the stats, and we haven't even started, and there's been over 200 shares on this session. Dr. Locke, unless you have any questions, do you have any other questions before we go to session?
No, I didn't. Let's get started. Thank you.
Exciting.
All right.
All right, with that said, you got the floor, Doc. We're gonna go ahead and be in the background taking notes.
All right, I'm assuming that everyone can see my screen now. And this is the
Yes,
topic
perfect.
for today's discussion is, both artificial intelligence and the oral systemic connection and how those two are being used hand in hand. So, before we have any discussion on this, we really need to make sure that everybody is aware that they know what artificial intelligence is. And it's basically just the simulation of human intelligence processes by machines. AI systems basically take lots of large quantities of labeled data and analyze the data faster than humans can do it, and in ways that, if we're careless, we can even miss. So, using artificial intelligence, you have chatbots that are fed, large quantities of text, can learn to generate lifelike exchanges with people. When it comes to image recognition, which, is used in medicine and dentistry to scan either histopathologic slides, scan images of people's gums, looking for gum disease, scanning 2D and 3D renditions of X-rays to comb through for diagnoses and assist. The ability to use the technology is growing rapidly. We've got tremendous expansion of computing power. Chips are faster. Memory is becoming cheap and plentiful. And we're in the perfect storm for AI. I mean, prior to AI, it would have been hard to imagine computer software connecting riders to taxis, or in the same way, supporting doctors in diagnosing patient illnesses and directing courses of treatment. Well, there's certainly a ton of literature out there that links the diseases in the mouth to diseases in the body. And as I mentioned before, the simplistic explanation for how this happens is bacteria in the mouth traveling to other parts of the body via the bloodstream. We know, and studies have substantiated, that gum disease increases the risk of head and neck cancer, that people with gum disease are more than twice as likely to die from heart disease and stroke, that diabetes and bleeding gums increase your risk of premature death by 4 to 7 times, and that bacteria that live in the mouth can cause heart disease, high blood pressure, strokes, etc. Tooth loss and gum disease increase the risk of Alzheimer's disease, and gum disease is one of the most prevalent diseases affecting humans. In the professional literature, we as dentists and even our physician colleagues are being inundated in our professional lives with high-level articles about the connection. And, of course, the bacteria that is most preeminently responsible for this pathway is one of the a bacteria that was quoted by George Haji Shingalis and Rich Darveau back about a dozen years ago as the keystone pathogen. And they pioneered the keystone pathogen hypothesis that basically says that P. gingivalis is the big boss bacteria that everybody else falls in line for and is driving this many of the diseases. So, there's a convention every 2 years. There's one coming up this year. I'm actually, I need to get it on my calendar, but there's a convention every couple of years of several hundred people that do nothing else for a living but study P. gingivalis. It's pretty mind-boggling. And since, I think, 1950, there have been over 100,000 articles written on PG. So what you've got is professionals being inundated, and yet many professionals just don't have the time to read this. Simultaneously, the general public is getting condensed or simplistic versions of messages that what's going on in the mouth, can affect their brain health, their heart health, cancer, etc. This magazine, The New Scientist, back in 2019, devoted an entire magazine to P. gingivalis. And the lay people literature is being bombarded, which means that conditions are right. Patients now are, when I was first in practice in the 80s and 90s, it was, you got to carry your gums or you're going to lose your teeth. We didn't really discuss with patients that, their whole body health was at stake too, because we didn't really have the evidence or the knowledge to do it. Now patients are getting bombarded with this. They're asking their practitioners. They're ready to, have this preached to them. They're ready for therapies. They understand that, what's going on in their mouth can affect their longevity and their quality of life. Okay, we know over 50% of people over age 30 have some form of periodontal disease. At my age, that number rises to 70, and even some statistics say 83% of individuals over age 60 have high quantities of P. gingivalis in their saliva. And we can simply test as many different salivary diagnostic companies out there. I've been working in the past with Oral DNA and Bristle Health and Direct Diagnostics, and now, of course, Viome, that provide deep insight from the oral microbiome, including presence of P. gingivalis. What we've got here is just a partial list that's growing on a daily basis of systemic diseases that have been positively correlated to P. gingivalis. Pretty mind-boggling. This is a who's who, what's what of systemic disease. Now, two theories have been promoted in the past. Number one, as I mentioned before, direct bacterial spread, leaving the mouth, entering the systemic organs. But the second theory is that the orally located PG infection is causing systemic disease from afar. This extracellular mechanism fits the existing data better. To really understand what the extracellular mechanism is, we need to know the word gingipains. Gingipains is a family of proteases. They're enzymes that break down proteins that are secreted by the organism P. gingivalis. And the body's immune response causes a host response in various organs. P. gingivalis has grown to thrive in its ideal environment, which is the subgingival tissues. It loves it there because it's an anaerobic bacteria thriving in low oxygen areas. P. gingivalis would not be a happy bug to live in the brain because the brain has the highest oxygen tension in the body. At the same time, mammals have a biologic barrier, the blood-brain barrier, which can prevent the pathway of most common bacterial organisms into the brain and nervous tissue. So P. gingivalis is actually unable to cross that blood-brain barrier. And even if it wanted to, it would be prevented. But when we understand what these gingipains are, they're produced from outer membrane vesicles that P. gingivalis releases, and they're actually the toxic enzyme protein poisons that cause inflammation in the gums in patients with periodontal disease. Now, we have fallout or secondary damage from that results in diseases of the body. But the primary goal of the organism is to promote itself and have itself thrive and live in the oral cavity. That these toxic proteins or gingipains are the chemicals or the poison that actually enter the bloodstream and cause disease processes in the body. Those gingipains can cross the blood-brain barrier. They do enter the brain. They do interfere with neuron transmission in the brain and are the culprit for dementia. In almost 100% of autopsied brains of people with Alzheimer's or people who have had Alzheimer's, we have found the DNA from the gingipains of P. gingivalis. That's not a coincidence, especially when we understand that the byproduct of the immune system interacting with the gingipains in the brain is beta amyloid plaque. More about that later. In addition to the brain, we know that the gingipains, these toxic proteins of P. gingivalis, also travel to the liver. In the liver, they are responsible for attenuating insulin sensitivity. What this means is the pancreas, which regulates blood sugar by directing insulin production in response to the appropriate the amount of sugar in the body, the insulin production should, under normal circumstances in healthy people, help the body metabolize glycogen, create energy that the mitochondria and our cells can use and drive our everyday existence. But when insulin sensitivity is decreased or interfered with, what happens now is the process of glycogen synthesis does not occur as it should. And blood sugar is not being appropriately reduced by what should be a proper amount of insulin. And basically what we have here is diabetes mellitus. So P. gingivalis and gum disease play a role. We've known that. Studies have shown that when we have a patient with diabetes and uncontrolled periodontal disease, their insulin is almost impossible to control by their physicians. And yet when those patients undergo comprehensive periodontal care, automatically, like magic, all of a sudden, many of these patients now can have their diabetes controlled, oftentimes with simple diet. So the connection is there. P. gingivalis is the culprit, the gingipains of P. gingivalis. In our blood vessels, P. gingivalis, or the gingipains of P. gingivalis that circulate, have been shown to promote dysfunction of the walls of the blood vessels. The body attempts to repair this damage with calcifications. Those calcifications narrow the lumen of our blood vessels, leading to high blood pressure, heart attacks, and strokes. So what you have here is an electron scanning micrograph of an organism of P. gingivalis, and the arrows are pointing to some of the many outer membrane vesicles that contain the toxic proteins or gingipains. Again, 75 to 85% of adults have some form of periodontal disease. The average adult, 3 hours of bacteremia per day from P. gingivalis into vascular cells. And if you think that a professional cleaning is the answer, unfortunately, within 7 days after a simple cleaning and 30 days after comprehensive therapy, P. gingivalis returns to the gingival tissues in pre-treatment quantities. This is a study that should be on every dental and medical person who's interested in the oral systemic connections, knowledge base. It's a very simple study postulated by Dr. Booth and his associates. The study, which is basically amounts to a phase 1 trial for a monoclonal antibody to eradicate P. gingivalis, was done in 1995, almost 30 years ago. And in this study, 14 patients with periodontal disease and high levels of P. gingivalis underwent scaling and root planing, and 7 of them had irrigation with saline after the scaling. 7 of them had irrigation with the monoclonal antibody. It was a murine, a rodent form of a monoclonal antibody. In the 7 patients treated with scaling and root planing and the monoclonal antibody, the earliest measurable return of PG in any of those 7 patients was 9 months after therapy. Unlike the control group that had saline, all experienced return of quantities of PG within 3 weeks after therapy. So what happened? Why didn't anyone pick up the ball and run with this? Well, they were looking for a cure. They were looking for a total eradication, a one-shot deal. So when the bacteria returned 9 months later, it was essentially deemed a failure. Well, here we are now and realizing this powerful tool. And when you're dealing with the knowledge that we have learned that the DNA from P. gingivalis have been recovered in virtually 100% of autopsies of Alzheimer's brains, and that our studies indicate this is mind-boggling. 38 to 50% of all Alzheimer's cases are caused by P. gingivalis. So by simply eradicating P. gingivalis, we could almost overnight eliminate 1/3 to 1/2 of new cases of Alzheimer's. And the remaining cases of Alzheimer's are impacted, if not initially caused by it. The severity of the disease process is impacted. So at the very least, we can have a benefit to those patients by reducing the rate of deterioration of their dementia. Now, until now, all therapies that are targeting Alzheimer's disease target a reduction in beta amyloid plaque and tau proteins in the brain. The patients with high levels of beta amyloid plaque and tau proteins in the brain have very advanced Alzheimer's disease. What we need to do is target patients who are still healthy and prevent the disease process from taking root. So there has been one systemic drug targeting gingipains, a systemic drug called atuzigenstat. It was blocked by the FDA when it was shown to cause liver toxicity. This was in the form of an oral pill that was targeting circulating gingipains. Well, there's got to be a better way, right? Why target circulating gingipains? If you do that, you're not doing anything to arrest the culprit, which is the P. gingivalis infection in the gums, in the mouth. So one of the companies I advise, Keystone Bio, has developed now an improved human chimeric form of the murine monoclonal antibody used in the Booth study in 1995, and the biologic will be in trials soon. Hopefully, we'll have product to dentist in a couple of years that we can supplement our prophylaxis and scaling and root planing visits with an irrigation of a monoclonal antibody that can eradicate P. gingivalis for a year or more and keep this process, this pathologic process away. So we're here talking about artificial intelligence, and how does that fit in here? How can Keystone Bio utilize artificial intelligence to have a more effective therapy? So how the team uses and is planning to use artificial intelligence in the future is helping it identify correct patient population for its biotherapeutic drug, and understanding patient populations that exist in multiple disease cohorts. Obviously, Alzheimer's is just one disease process. So there's a need for a multifactorial understanding of how the disease actually processes, begins and progresses. Sifting through data to see how patients are responding to therapy. Faster target and biomarker identification, working with huge data sets of information that are just going to be impossible to deal with without the computing power of artificial intelligence. Learning how the protein docks on the antibody, and how we can target the bacterial protein target engagement complex requires multiple approaches that in the past would be a needle in a haystack approach, that now, thanks to AI, we've basically hit gold early because of the ability to really focus on data that directs us to the proper solution. The down-selected monoclonal antibodies requires some molecular engineering to improve binding. AI is used for that. And the bacteria target molecule and reduction of future anti-drug antibodies that could affect the potency and safety of the drug all require AI. Lastly, we're using guided protein crystallography, structural analysis, and molecular engineering to a future first and second generation antigen for developing a vaccine against P. gingivalis. You know, much like we have vaccines now against HPV in the form of Merck's Gardasil vaccine, we envision in the not too distant future, hopefully, a vaccine that we can administer to adolescents who haven't been exposed to PG yet and prevent them from ever having to deal with this bug. Now, Keystone Bio's therapy is a couple of years away. It's very exciting, but I'm also working with a company, Viome now, that actually has therapies and approaches that are at work for us now. And in addition to taking deep dive at the oral microbiome, Viome also has the first ever non-invasive test to detect oral and oropharyngeal squamous cell carcinoma from a simple salivary screen. And this has been available to dentists now in the United States for the last 6 months. Since last June, when this rolled out, dentists are doing this now in their offices. What happens is the patient needs first morning saliva for this test. So patients are being enrolled in the office. We're screening we're recommending screening of almost every patient. Initially when we brainstormed this, we thought, hey, who's our target population for this? And initially it was an oral cancer screen only. And we thought, wow, we know people over 50 are at higher risk for oral cancer, people who are heavy smokers, heavy drinkers. But when you throw in the fastest growing etiology of oral cancer being human papillomavirus, an HPV infection, well, now you're throwing in there the risk of oral cancer in any patient who's sexually active. So basically, we need to test everybody. Everybody's a candidate, and with a simple screen, we can find patients with a positive biomarker test for oropharyngeal cancer, even before that white spot or red spot or lump is noticed. And we all in the profession know that early diagnosis means higher success rates and better quality of life for oral cancer survivors. I'm ashamed that as a dentist for 45 years, that the 5-year survival rate for oral cancer is still hovering at around the same 50% that it was when I first became a dentist in 1978. And I'm excited to be a part of this movement to detect more cases of oral cancer earlier. But Viome doesn't stop at oral cancer detection. Viome does a deep dive and develops 6 scores, a gum health score, cardiogenic activity score, breath odor health score, pathobion activity score, fungal activity, and genotoxic activity. And the last 2, the fungal activity score and the genotoxic activity score, are the largest predictors and have the most factors that go into the biomarkers that we develop at Viome that determine whether the patient either currently has a detected positive biomarkers for oral cancer or at risk for future. So if you've got a patient with a non-detected, like the sample here, a non-detected oral throat cancer, but this patient has a not optimal fungal activity score, as you can see here. This patient is at risk for future oral cancer. And Viome will direct us in both environmental and recommended treatments that the patient can do at home, and also at professional therapies that we can do, both directed at improving the patient's fungal activity score and making their oral health and their oral microbiome a healthier place for them. And if you look at the detail of the gum health score, the practitioners who have patients do these screens will get 6 detailed pages on each of those 6 categories, in addition to the oral cancer score. Here, the sample patient had a score of 34, which is not optimal. There's some talking points in here to discuss with the patient. And as you can see, about 2/3 of the way down, the risk factors that this patient has by virtue of having a non-optimal gum health score put them at risk for heart disease, cognitive decline, metabolic disease, and inflammatory bowel disease. And we've identified risk factors relating to all 6 of these categories. So what we really have here is the equivalent of our blood. When we go to physicians for a physical, a fair amount of the time is spent going over our blood results. And in the same way with saliva, dentists have the ability to do a deep dive into what's going on in the oral microbiome of our patients and affect a positive change to that. And basically do it in a way that gives us a tool that can show patients, that give more credence to the recommendations we make. I know in talking to hygienists and dental colleagues that periodontal disease is one of the most refused treatment plan options given to patients. And if you think about it, from my years as someone who really focused on treating phobic patients here, they've got gum disease, and they don't always correlate it with what they're aware of. It's often painless. Teeth only not until late stages of the teeth loose. The gums bleed. Well, somehow we've let them accept gum bleeding as something that's, quote, normal. If their eyes or ears were bleeding, they'd be at their physician's office yesterday. But a little gum bleeding, well, I brushed too hard or I flossed too hard. So we've been guilty of not putting enough emphasis on periodontal care. And part of it is that patients hear this, they think expense, they think pain, they think time, all things that they don't want to do. And historically, going to the dentist gets pushed down to the bottom of our patients' lists of things they both want to do and want to spend their limited finances on. And so what we're doing here is promoting their understanding of what's going on in their mouth and driving their acceptance of our recommended care. And we can equate the different species of bugs. This is all based on studies. You see Alzheimer's, P. gingivalis, and spirochetes. If you look at almost every category here, you will see Porphyromonas gingivalis listed in almost every category. It's been correlated with all these conditions. So how does Viome break down the saliva and really understand and figure out what's going on? Viome's molecule of choice is RNA. Most other microbiome testing, be it gut microbiome, which is where Viome started 5-6 years ago, or salivary microbiome, are working on either just giving reports on bacterial identification or on DNA. DNA doesn't change during our lifetime. Our DNA is the same when we're born. It's the same when we're alive. It's the same when we're dying. But RNA is an active measure of what genes are being expressed. The problem is that the data is huge. So most companies have not figured out how to tackle it. Viome has some competitors in the gut health space. These companies Biome and Flore, but all those use DNA. This is an independent article by a scientist, a PhD scientist in New England, who lauds Viome on the use of RNA, the only company that is telling you not only what microbes are present, but whether they're playing a role in body functions. Altogether, Viome is sifting through over 750 trillion RNA nucleotides that they've sourced from over 500,000 samples to date. From that, using artificial intelligence, they're able to target certain molecular features, certain phenotype metadata points, and they've come down using this huge quantity of data to 30 predictive models that can uncover mechanisms for aging, obesity, diabetes, IBS and IBD, oral cancer, etc. So understanding these interactions between expressed genes is basically the core of Viome science. And this is a diagram of how this biomarker score for determining the presence of oral cancer comes to. I mean, it's pretty mind-boggling, all these different microbial pathways and host pathways that we're looking for. And all this is data culled from the mRNA information obtained from the saliva. Again, even when tests come back negative, we have insights into markers associated with malignancies. So I mentioned fungal activity and genotoxic activity scores are super important. So what does Viome do with the data? There are other companies touting probiotics and prebiotics. Viome actually in the mouth creates, and this is available now, custom oral lozenges based on the individual's salivary microbiome. So what is a probiotic or a prebiotic or a postbiotic for that matter? It's a buzz term that we've all heard about. What we need to realize is that the mouth is full of organisms, many of them which produce nitric oxide, which is an essential ingredient for health, are good bacteria. And the good bacteria and the bad bacteria are competing for food sources in the mouth. So with this huge quantity of data that we have, what we're able to do is we're able to individualize the probiotic therapies for patients that give their positive bacteria, their healthy bacteria, a competitive edge. We want to starve the bad bugs and feed the good bugs. So unlike a Keystone Bio, which has a direct biologic in the pipeline to eradicate P. gingivalis, the approach here is by working with the existing oral microbiome to favor the growth of healthy bugs. And this is how Viome uses AI to improve treatment efficiency. So again, bioinformatics for making sense of the huge amount of data they get from mRNA sequencing. And then the oral health scores that you see are obtained by assessing the activity of the biochemical pathways that are comprised of these transcripts. developing nutritional recommendations. So in addition to the customized lozenges and toothpaste, Viome will make dietary recommendations for certain foods that can target the biochemical pathways going on in that individual that need improvement. And a lot of that is reflected in the breath odor score. So our patients with non-optimal or suboptimal breath odor Viome Oral Health Pro scores are patients that are in need of some nutritional recommendation and alteration in their diet. Biomarkers and target discoveries for determining patterns of molecular functions that are different in disease cohorts relative to healthy cohorts. So once we've got that data and we can examine, hey, what's different in people with, oral cancer? This helps us target the patients who may have full-blown oral cancer cases later on and let us diagnose them at the early stage. In addition, Viome uses AI on the customer service and internal productivity ends for improving the efficiency of their service, content creation, and engineering activities. And their organism catalog currently has over 40,000 individual reference genomes of microorganisms that are curated using AI to include only the highest quality ones. On P. gingivalis, and this is really big. On P. gingivalis, Viome uses AI and the bioinformatics required for determining gingipain activity. Other salivary diagnostic companies can tell you if you've got high levels of P. gingivalis, and there are patients that can survive with high levels of P. gingivalis that do not have high levels of circulating gingipains. Not everyone with high levels of P. gingivalis is at risk for dementia, for heart disease, for diabetes. How do we know? How do we know who's got high levels of gingipain? Viome can tell us. Viome has the ability with their AI to determine from the mRNA activity whether the individual has high levels of circulating gingipains. So further, they can detect specific strains. We currently have identified over 150 different strains of PG. And in a recent story that I saw out of China, also using AI, they determined that there are 2 specific strains of P. gingivalis that have been associated with Parkinson's-induced cognitive impairment. So what we are hypothesizing, what scientists hypothesize, is that each of those different strains of P. gingivalis may have a propensity to instigate a specific systemic malady. Certain strains, for example, specific for heart disease, certain strains for diabetes, certain strains for rheumatoid arthritis. And Viome's role here in being able to identify specific strains of P. gingivalis will be to highlight an individual's risk. So targeting an individual's risk, for example, for rheumatoid arthritis. Huge stuff we're working on here. I briefly mentioned Proteocyte is a company that is working with a population of patients that go beyond what Viome has seen. So for example, Viome is helping us find oral cancer even at its early stage before we see a lesion. What happens when we do see a red spot, a white spot, and we send those to an oral surgeon for a biopsy, and it comes back negative? In those patients, Many of them hear you don't have oral cancer and they're out the door. But the reality is many of those biopsies result in some amount of dysbiosis or changes on a histologic level that put that patient at a risk for future oral cancer. What is the oral surgeon to do? So case one, by a low risk determination by standard methods after an original biopsy on the left, that patient probably did not have any further care. The Stratocyte, which is the AI test that is done by the company Proteocyte, determined that the lesion had a medium risk. So in running it through their AI, comparing the histologic features, looking for certain specific proteins, Stratocyte was able to determine that this patient had a fairly significant risk. So in patients like that, we have a tool to determine which patients with negative biopsies for oral cancer should still have aggressive therapy on their lesions. Okay. Here's one. Conventional diagnostics determine this lesion to be low risk, but the Stratocyte assessed this lesion as high risk. 61. What that score 61 means is that that patient with that lesion has a 61% likelihood that in the next 5 years, that lesion is going to become malignant. So doctor and patient here, based on that information, opted for preemptive surgery. The surgery can be, traumatic, so we don't want to do surgeries on patients we don't have to. But again, it's a tool here to help determine, and you can see the healthy result on the right. Had that patient not been treated, who knows what that patient would look like 5 years later. They might have no tongue. They might have a complete hemimandibulectomy, neck dissection, you name it. We've done a huge service for a patient. And what Proteocyte has done here is utilize the AI. And one of the things they look at in the histologic samples is the protein S100A7. It's associated with poor treatment outcomes in patient with oral cancer. No one is looking for S100A7 right now, except for Proteocyte in their Stratocyte test. So they utilize the original biopsy. It doesn't require any extra tests. They use histochemistry, immunohistochemistry to identify the protein. They're also using digital imagery and computer-driven AI for entirely objective analysis of both cellular content of it and cell morphology tissue to come up with their 5-year oral cancer risk. And again, just mentioning my role with Revere Partners, the first independent venture fund for oral health, as an essential support for companies that need to raise funds. And I'll leave my contact info here, both my email address and my Facebook page, Painless Social Media, where people can reach me. And we'll return back to our Q&A part if anyone has any follow-up.
Wow, that was a very detailed presentation. Thank you so much for that. I have some questions. I'm sure Dr. Locke has some questions. I'll start with you, Dr. Locke. What question might you have as a newcomer to this topic?
Dr. Zuckerberg, you mentioned about the Keystone Bio, the vaccine. How far is it for the developing the vaccine to prevent P. gingivalis?
So originally, Keystone Bio was going to trials in phase 1, which is safety and efficacy, essentially doing what was done in 1995 by the Booth study, using the same murine monoclonal antibody. What's happened is utilizing AI in the last year or two, They've come along much faster than they expected with the human chimeric version of the monoclonal antibody, which will be way more effective. The murine monoclonal antibody showed enough promise for us to be very excited. I mean, just removing P. gingivalis from the gingival tissues for 9 months was on target to help tons of people. With the human chimeric version now, we can look at potentially a more effective and longer lasting removal of the bacteria from the mouth with the treatment, and hope less potential for any toxicity or anything of that nature. So what this meant is that the phase 1 trial, which was originally going to start with the murine monoclonal in 2022, is now pushed back to the end of 2024, the current year. So phase 1 again will be with a just population of patients with measurable high amounts of PG in their mouth, and we're going to be just measuring the levels of PG after therapy, and we're also going to be doing blood tests on those patients, looking for any signs that there is any toxicity in the liver or anything like that. Then in 2025, we anticipate a phase 2 specifically for Alzheimer's disease. Obviously, Alzheimer's has the biggest bang, and there will be in the need for the future, you need to do a phase 2 for each therapy. So if you want to show this monoclonal antibody is effective against heart disease, you got to do a phase 2 on that. If you want to do it, for digestive cancers, you got to do a phase 2 on that. The nice thing about Alzheimer's is while cancer can take many years to come up with a comparison for a study group versus a control group, you can do in relatively short order. So in a phase 2 where you've got patients with high levels of P. gingivalis and early dementia, and then the control group is not going to get the monoclonal antibody, and then you can track those patients and get great data in less than a year on what happened to the rate of progress of dementia in the 2 groups. So we're looking at phase 1 in end of 2024 and phase 2 in 2025 with a human chimeric version of the monoclonal antibody. And obviously that means the company needs, is raising more money, because reworking the monoclonal antibody and, bringing the trials is not inexpensive. Regulatory is a huge hurdle for any company that's involved in biologic and pharmaceutical therapies.
So this is very exciting. What can you run us through an idea of what we would be looking at as a clinician if you wanted to submit a sample and diagnose? I mean, early detection is extremely important, and the treatments that we can render to these patients, our colleagues in medicine. So at what point are you suggesting this is done on every patient that comes to the door? Are you suggesting this is done on susceptible patients? How would one submit the sample? How does that work?
I think that you want to do, make it a practice to test every new patient. I think that it's incumbent upon each dentist and physicians as well, but each dentist especially needs to really change the public's view of our role in their healthcare. We need to be looked at as a partner in their overall health, not just someone who fixes their teeth. And so when we do a Viome Oral Health Pro with cancer detect test on every new patient, and then review the results with dietary recommendations to improve their scores and probiotics and things of that nature, and the treatment that we give is focused on not just dental health, but in protecting their future systemic health. Now that patient views us differently than they've ever viewed any dentist before. And when it comes to existing patients in our practice, obviously no-brainer, patients who are smokers, patients who are drinkers, elderly patients, patients with any white patches or suspicious lesions in their mouth of any kind, those are no-brainers. But as I mentioned before, when you throw in parameters and etiologic causes like sexual activity, we're basically saying that almost every patient who's reached puberty in your practice should have a Viome score at least once. And then patients who have, if they're scoring green in all 6 categories, you may elect to not do another score on that patient for 3 to 5 years or more. But patients who are scoring in the red zone or have non-optimal genotoxic or fungal activity scores, which put them at a risk for oral cancer, the Viome test should be repeated annually. And patients who have non-optimal gum health scores, if we're going to get them to accept a periodontal treatment plan, we want to reinforce how effective our therapy is by having them go through another Viome test at the end of care, maybe 6 months later, that shows them, hey, look at that. After the treatment that Dr. Zuckerberg or Dr. Shah did on me, now my gum health score is in the green range. That's wonderful.
Fantastic. So, wow, life-changing. Dr. Locke had a question, please.
So Dr. Zuckerberg, the test that you mentioned, usually it's a RNA, and some scientists said that how can you, by the time we obtain the saliva test, and by the time we send it to the lab, the RNA may break down, things like that. How would you respond to that kind of statement?
That's not an accurate statement in my knowledge base. Viome uses a preservative in the sample. The patients are collecting first morning saliva in a tube that is prepared with a small amount of preservative that doesn't alter the sample, but keeps the sample accurate for at least 30 days.
Wow.
And then the patient is dropping it. The patient's doing it at home. So the workflow process is the doctor or the hygienist or the staff member that advises the patient that they want their Oral Health Pro and Cancer Detect score from Viome. Once the patient agrees to that, the doctor or staff member goes onto their Viome portal on their computer and enters the patient data, email address, birth date, simple stuff. From that point, Viome triggers an email to the patient to accept the care. And the patient has to pay for the test. So ultimately, we'd love to get, and we're working on showing medical insurance carriers the benefit to them of paying for this test as a medical test. Until that happens, patients are direct paying $299 for the test right now. So the patient will pay for the test. The tube is sent to their home. They'll collect first morning saliva. They'll throw it in the mailbox. Viome will have the sample within a few days, and Viome will process the test on their end and then notify the doctor in their portal of the test result. So the doctor will get the report that I showed in the screen sharing today of the patient before the patient sees the report. And the doctor will download the report in PDF fashion. And then, depending, obviously, if there's a positive biomarker for oral cancer, you're going to want to bring the patient in person. Otherwise, it's suitable to a telehealth call where the results are reviewed in much the same way that I reviewed the proposal, the presentation with the audience today virtually. The office can have a qualified staff member who's earning somewhere between $40 to $50 an hour doing Viome calls from home all day to patients, maybe 2 every hour, generating a billable visit at $150 a visit, that will be paid for. There are CPT codes that medical insurance will pay for the time the doctor spends reviewing the results on the report. So you could have an employee at home or a staff member during a downtime, a patient cancellation, have the hygienist do it or whatnot. Staff member from home could be doing to an hour, 16 reports a day. You know, that staff member's generating $2,500 in revenue for the practice, not to mention increased revenue from procedures like more patient case acceptance of gum therapy and other procedures recommended as a result of the Viome scores.
Thank you very much. I have
Excellent.
another question. The test gonna test not only the risk factor as well as let's say the patient already have cancer. Would it be something that they say, okay, you got positive cancer, or is it just one of the way to test?
So the positive biomarker test has a 95% specificity. So if we highlight a patient with a positive oral cancer biomarker, in 19 out of 20 of those patients, there's some amount of oral cancer could be traced going on in their mouth as tipped off by our biomarker analysis. And from that diagnosis, obviously, you know, most of us are doing thorough head and neck and oral cancer exams on our patients at every recall visit anyway, and new patients. We're gonna review anything that we might have seen and didn't think it looked suspicious. Now with a positive biomarker, you know, anything that looks remotely suspicious is going to be recommended to be biopsied. And because we're also able to detect oropharyngeal squamous cell carcinoma, we need help from an oral surgeon or someone, or a head and neck surgeon, someone who can do a throat evaluation. Maybe that patient needs an endoscopy. Something we can't obviously do in our office, but something that should be part of the follow-up for any patient that has a positive oral cancer biomarker.
Thank you. One last question.
So you don't go ahead.
Yeah, go ahead.
But I wanted to reflect on the insurance thing that he brought up. Do you foresee any dental insurances? I'm not that I'm a big fan of insurances, and I don't think they should ever meddle with procedures that would improve patients' lives. But do you think this is something that should be covered? We're talking about saving a lot of lives, saving a lot of.
Not only do I not see it covered by dental insurance, but I would love to see dental insurance done away with altogether. You know, as most of us are aware, there are currently laws being put through in many states with loss prevention ratios. I think Massachusetts was the first state that pioneered this, that basically said that for every dollar paid in insurance premiums, 85% has to go back in benefits to the patients or the doctors who.
Doesn't.
True. It doesn't in every state except for Massachusetts. And what that law will essentially do is drive dental insurers out of the dental market. This is great news for dentists, because dental insurance, I believe, is the #1 inhibiting factor in us really taking our practices. You know, dental insurance was originally, when I started practicing 45 years ago, was supposed to be our partner and help, you know, drive traffic, drive business for us. And it did. For me, starting out as a brand new dentist, you know, in 1978, it did. But right now, it's the problem. It's not a support. They undermine what we're trying to do. They tell patients that the patients could have saved money by going to an in-network dentist if you're not in-network. They imply that our fees are too high, or that the treatment that we're recommended is not necessary. So dental insurers are not our partners. Medical insurance pays for medical diseases. Periodontal disease there are CPT codes for periodontal disease, and periodontal disease is a covered treatment by medical insurance. Go try and do it without real knowledge base, and it's a problem. But what you have to look at, when I was a dentist, when I was first in dental school in the 70s, sealants were being pioneered. And dental insurance carriers were looking at claims for sealants, and they're going, wait a minute, you want us to pay for something on the tooth where there's nothing wrong? And over the years, we got to show them that when we applied sealants to the occlusal grooves of a permanent molar, over the course of the patient's lifetime, the insurance company saved money because that tooth wound up with a much lower likelihood of needing extensive care, fillings, restorations, root canals, crowns, extraction, implants, you name it. When we're talking about reducing the risk of dementia and heart disease, we're not saving dental insurers money on that end. We're saving medical insurers money. So the domain for paying for this test needs to come from insurance.
I wanted to add to your comment. I'm very happy that you take the position that insurance should be done and gone away with. If you ask, we operate right now in over 100 countries with our colleagues, and the topic comes up over and over. By far, the number one problem we are having in dentistry is these insurance company who sort of invited themselves in, and it's a hard problem for us since we're isolated and we want the referrals. And so when I started 17 years ago, the fees were just about the same for a crown as they are today. I don't know about you, but they don't increase their fees. They don't consider inflation. They're practicing without a license because the minute they say we are doing unnecessary care, where is your license to tell me that I'm doing unnecessary care? So they're around about the way. They have figured out how to get around the state practice acts and basically dominate doctors, and they gotta go. So I will always be supportive of that fight if you run across that for trying to get this approved. And I certainly think that the candle is slowly going out for the insurance companies. And this was actually very good news with this law that's coming in. I'll be very much looking into that.
Don't get me started on PPOs. It's a lazy dentist way of filling their chairs with patients. But you're going to be an employee of the insurance company. The work you do and the kind of practice you have is going to be dictated by someone else, not made by yourself.
It's not the violation of the first rule in health and medicine is not to let any outsider interfere with the patient-doctor relationship.
Well, the real world. Welcome to the real world.
The real world. Well, Dr. Locke, wow, what a session. Do you have any other questions for Dr. Zuck?
Last question, maybe, or Dr. Zuckerberg, the last time you touched base on Keystone Bio, they developed the therapy treatment with a gel technology. How far is that going along?
Well, like I said, we revamped plans for the phase 1 trial, pivoting to using the human chimeric version, which is very exciting. So, if things progress on schedule and phase 1 is this year and phase 2 for Alzheimer's next year, within a couple of years, we could have a gel ready and approved for use by dental professionals in office to start making an immediate impact on patients' future systemic health.
Thank you.
It's an honor to have. Go ahead.
You mentioned about
sorry,
Doc. For the test called Stratify, is that the third company that you're working on?
I'm sorry.
The test that the test called Stratify test.
Yeah, Proteocyte is the name of the company. Proteocyte. That's a separate company from Keystone Bio and Viome, and they are specifically in the space of dealing with histologic samples of oral lesions that have already been biopsied and have a non-malignant diagnosis, but
Right.
with some risk of future malignancy. And right now, what does the oral surgeon do? They just did a biopsy. There's some changes, but the bottom line is the diagnosis they're delivering to the patient is you do not have oral cancer. And a lot of patients hear that and they're out the door. Okay. But the reality is they're not out of the woods. They do have some tissue changes in the sample that was biopsied. And those tissue changes put them at risk. And until Proteocyte and their use of the Stratocyte test, which utilizes artificial intelligence, until that test is available, our oral surgeons and head and neck surgeons who are doing biopsies on the lesions we send to them, they're flying on the seat of their pants. They're like, well, I think we should cut this lesion out, but it's not going to be fun. It's going to hurt the patient. It's going to be uncomfortable. It's a big procedure, and they may not ever get cancer. So we may be overtreating them. On the other hand, they don't want to undertreat and have the patient develop a serious case of oral cancer that they could have prevented. So right now, Proteocyte is filling that gap of taking how to treat these patients with non-malignant biopsies and with some cellular changes that point at some risk, and using artificial intelligence, they're able to quantify the risk. They're able to put a number to it. You have a 32, a 12, a 4, an 87% chance, whatever it is, that this lesion will be malignant in 5 years. And now the patient and the doctor have concrete medical score to base their decision on whether to go aggressive or conservative with follow-up therapy.
Super beautiful, Dr. Zuckerberg. Is there opportunity for dentists like us to invest in any of those companies that you talk with?
Well, as I mentioned, there's two ways. There's investing through Revere. Revere partners. Revere invests in. Revere looks at over 100 different companies in the oral healthcare startup space each quarter. And each quarter, Revere invests in four companies. And we have a team of the top key opinion leaders from all walks of dentistry and healthcare. And our team is brainstorming together and looking at each of the companies to narrow the field down to 4 companies. So with such a wide choice to select, we're coming up with 4 very good companies each quarter. Now, the investor doesn't necessarily know who their investment is going to be put into. But if they invest in the Revere funds, they know they're going to be investing in, over the course of a year, in 16 different oral healthcare companies that Revere has carefully selected. Now, Revere also does partner with companies like Viome, like Keystone Bio, to have also direct investment opportunities in the company. And companies like Proteocyte do accept direct investment from dentists into the company. So anybody who has any interest in becoming an investor, either through Revere or directly in one of these companies, should reach out to me at ezuckerberg@gmail.com or by messaging me a direct message on my Facebook page, Painless Social Media.
The social media. Excellent. So you guys got that, the email, as well as the link you guys can go to for direct messaging. So Dr. Zuckerberg, Dr. Locke, thank you so much for your time on a Sunday to further the knowledge and information that we need to provide better care to our patients. You come from a family of where you guys tend to impact a sort of the way humans do things, and now on a technology side as well as the medical side. It's very honorable, and your story of how you took dentistry and what dentistry has been able to provide to you and what you got out of it in your career is very inspiring. I look forward to utilizing the product actually in my office, and the next time I see you in person, I'd like to get started on that. And thank you again so much. We look forward to having an update from you. Hopefully, in 6 months to a year, we'll have you back on the podcast, and you can let us know how you're progressing with this project.
Great. I can't imagine what changes there'll be, but I'm looking forward to living through it.
Thank you
Thank
so
you very
much.
much, Dr. Zuckerberg. Thank you, Dr. Shah. What a beautiful Sunday.
Take care.
Let's
Have a
start
great
on Sunday. You
Thank you.
too. Take care. All right, we're off.